Much. Well, we want to welcome you, everyone. Thanks for being here today, and welcome to our fourth presentation in our All About Alzheimer's monthly series, where, as usual, we hope to bring you useful information that you can take back with you, either to your respite or support group, the role that you have in that setting, or if you are caring for someone living with dementia or Alzheimer's. So we hope that this information will be beneficial for everyone in attendance. As always, it's a pleasure to be here with you today. Again, my name is Joan Asseff, and I'm a licensed clinical social worker here in the state of Texas. I have the distinct honor of having spent most of my career working with older adults and their caregivers in a wide array of settings, including skilled nursing, hospice, home health, psychiatric care, and private clinical practice. So you name a setting and I've probably worked in it. And I loved all of those settings. But I now teach clinical social work practice at the Steve Hicks School of Social Work at UT. And I really love this work as well. I'm teaching future social workers, and I do specifically focus in the area of gerontology and work with caregivers. So I'm still doing that work now in academia. So again, I just want to lift up and recognize the selflessness and determination and extreme care it takes to support folks living with Alzheimer's and other dementias. And I'm excited about these sessions where we can collaboratively problem solve and think about solutions with one another. So with that, we'll go ahead and get started. Oh, and I wanted to also just add to that, as you heard, we're recording, and we welcome your questions and discussion at the end of the presentation. So just a quick note, as usual, about Alzheimer's Texas before we get started. I'm sure many of you know Alzheimer's Texas is an independent local nonprofit that used to be known as the Alzheimer's Association, Capital of Texas chapter. They have been a privately funded voluntary health organization since 1982, quite a long time now, serving Central Texans with Alzheimer's disease and their caregivers. About 3 or 4 years ago, Alzheimer's Texas broke away to form their own nonprofit and decided to focus 100% of their funds and efforts here in Central Texas. However, Alzheimer's Texas maintains the same level of commitment, providing support, education, and advocacy for those affected by Alzheimer's in our community. Alzheimer's Texas continues to carry out its vital mission to eliminate Alzheimer's disease, yes, the day that we're all looking forward to, right, and related disorders through the advancement of research and to enhance care and support for individuals, their families, and caregivers, which is part of what we're doing today. So as any good academic, of course, I always have to bring you some learning objectives. We want to understand the key aspects of a short-term rehabilitation stay. What are those key elements, including admission, plans of care, and discharge planning. We want to learn strategies for self-advocacy and effective communication with various individuals and departments within a skilled nursing facility. We also want to formulate key questions to help caregivers develop a well-informed plan of care for their loved one with dementia. And then, as always, we want to think about and share ways we are supporting ourselves and others who are experiencing a short-term stay in a skilled nursing facility, recognizing that it's a very complex process and there's a lot of information to take in. All right, so when we talk about admission to a skilled nursing facility, we really have to start with the Medicare Part A funding piece. Now, I recognize that not everyone being admitted into a skilled nursing facility is utilizing their Medicare benefit, but for the most part, many folks with Alzheimer's are using their Medicare benefit. I welcome you to reach out to me individually if you have a kind of more specific question around a different insurance. But today I want to focus on Medicare Part A. So we don't have time today for a comprehensive review of Medicare coverage. That would take hours. But I wanted to provide an overview of Medicare funding for a short-term skilled nursing facility stay, because this is really important information for caregivers to have and for those who are supporting caregivers to have. First, a patient must meet medical criteria for rehabilitation in a skilled nursing facility to be eligible for a short-term stay in a skilled nursing facility. This means that they must be able to participate in rehabilitation services. It could be physical therapy, occupational therapy, and or speech therapy, but they must be able to at least engage in those therapeutic services for their stay to be funded by Medicare. Some brief skilled nursing care, meaning only nursing services without rehabilitation services, can be covered under Medicare, but it's usually limited to 2 weeks or less. So, just to be aware that if a patient is going in to a skilled nursing facility for nursing care only, that likely their stay is going to be shorter because Medicare Part A primarily focuses on those rehabilitation services. Patients must also have a 3-night hospital stay to activate their skilled nursing benefit under Medicare, and that's their skilled nursing facility benefit, that is. This means they must spend 3 midnights admitted to the hospital. If a patient spends time in the emergency room for observation, that time does not count toward the 3-night hospital stay requirement. And that can be very confusing for caregivers who say, oh, my loved one has been in the hospital for 3 nights. They should have their benefit. But if they were in observation for even one of those nights, they do not qualify at that point. After the 3-night hospital stay, the patient has up to 30 days to admit to a skilled nursing facility and use their Medicare Part A benefit. So if the patient goes home, it's important to keep track of how long they have been out of the hospital, especially if there is some question about whether or not they might need to go into a skilled nursing facility. So it's really important to track those days. What else? So I want to make sure that everyone understands that when someone is admitted for a short-term stay, patients are eligible to receive physical, occupational, and speech therapy along with skilled nursing. So they are eligible for all of those services. They're also eligible for dietary and social work and recreational services. It's also important for patients and caregivers to know that their loved one must be able to continue participating in rehabilitation to remain covered under Medicare Part A. This fact is especially important for caregivers of those living with dementia because they might have more limitations on fully participating in rehabilitation therapy. Patients must be able to make what's called functional progress or functional gain, meaning they are gaining skills, even ever so slightly, related to their activities of daily living. For example, a patient who was only able to walk 5 feet last week can now walk 15 feet this week. This type of functional progress must be made for a patient to remain covered under Medicare Part A for the short-term rehab stay. Something many caregivers and patients don't realize, this is another really important point, is that Medicare does not cover a long-term care stay in a skilled nursing facility. It simply does not cover long-term care. This means if a determination is made that a patient needs to transition off of the rehab therapy because they are not making functional progress, they will no longer be funded by Medicare Part A and will transition into a long-term care status within the facility. Only Medicaid or long-term care insurance covers long-term care in a skilled nursing facility. There are VA benefits that can also cover long-term care, but for the most part, Medicaid and long-term care insurance are the only types of coverage for long-term care. And this is just a really important fact that a lot of caregivers don't necessarily know. And when I worked as director of social services in a skilled nursing facility, I was often reviewing this information, and it might have been the first time that many caregivers had heard this information. Here you can see an overview of the Medicare Part A skilled nursing facility benefit period. The first 20 days are covered at 100%, but after day 20, the coverage drops to 80%, another really important point for caregivers to know. The copay after day 20 goes up slightly every year. So every year Medicare kind of increases that copay. And currently, today, that copay is $185.50 per day after day 20. And that's why this is so important, because the cost of that copay per day can really add up for caregivers, for families. So, you know, a 20% copay might not seem so challenging, but when you think about $185.50 per day, it absolutely can be. Many patients use supplemental insurance or Medicaid to cover this copayment, but not all patients carry supplemental insurance. It's really important to assess a patient's insurance coverage upon admission or even before, right, to determine whether they are able to afford staying after day 20. 20 days can go by very quickly when you are recovering from a surgery or a significant medical event, such as a stroke. And then after day 100, Medicare no longer covers the short-term rehab stay. Medicare Part B might continue to cover rehabilitation services, but the room and board becomes the patient's responsibility at that time. I've included a few more important coverage details here for caregivers to remember. Number one, a patient with Medicare coverage resets, meaning they get a new benefit period, a new skilled nursing facility benefit after 60 days of what is called wellness. Now, what do we mean by that? Well, we mean that the patient has not admitted to a skilled nursing facility for 60 days. So they really do need that 60 days of wellness for this benefit period to reset. Once a patient has been discharged from the skilled nursing facility for 30 days, again, 30 days is a key number to remember, they need a new 3-night stay to activate their benefit again. So the good news is there really are, as far as I've ever seen in practice, unlimited benefit periods, but you need that 3-night hospital stay to reactivate the benefit. And then you need 60 days of wellness to restart the benefit. So I know it's a lot of information, but that's why this slide is here. So if you wonder later, what was all of that Joan said, this slide will be available to you. And of course, you're welcome to reach out with questions. I will also say that Medicare.gov is a pretty easy website to navigate, and they have all this information as well. All right. With the passage of COVID-19 support legislation, there is now additional flexibility for some people to get renewed skilled nursing facility coverage without having to start a new benefit period. This language that I've included here comes directly from the Medicare.gov website, and I recommend contacting 1-800-Medicare or researching these changes on Medicare.gov because they are very new. And a lot of facilities still might not fully understand them or know how to implement them. These changes might not be universally applied, even though they should be, but they might not be universally applied or understood across skilled nursing facilities. Really, the social worker or the case manager in the hospital is going to be your best resource around these changes because they really have to know this information because they're discharging folks to skilled nursing facilities all the time. But I just mainly wanted to make everyone aware that there are some additional opportunities to access skilled nursing facilities without having that 3-night stay, but you really need to consult with the hospital social worker or case manager to know what those are. All right, so selecting a skilled nursing facility. You know, when a loved one is in the hospital with a change in condition, it can be especially stressful to go through the process of selecting a skilled nursing facility. There are some supports and resources in place for caregivers in this position, but the responsibility for completing this task falls mostly on the caregiver, unfortunately. The hospital social worker or case manager should make referrals to at least a few skilled nursing facilities, and they should reach out to those facilities on the caregiver's behalf to determine if they have a bed available for the patient. It's important for caregivers to remember that they are not limited to the skilled nursing facilities referred to them by the hospital case manager or social worker. Caregivers can consider any skilled nursing facility in their community as long as they have a bed available. They take the patient's insurance, and they assess that they can meet the patient's care needs. So those are kind of the three variables there. The hospital social worker should be able to send the patient's records to any facility a caregiver has identified and requested for that information to be shared with. If at all possible, it's important for caregivers to visit the skilled nursing facilities they are considering. Even nursing facilities that have a good rating through Medicare might not be the best fit for a specific person, especially folks living with dementia. For example, if a patient with dementia is triggered by crowded places with loud noises, then a lively nursing facility with lots of kind of constant hustle and bustle might not be the best fit for that patient. For a patient with these needs, a smaller facility that's spread out with quieter areas might be a better fit. During their visit or tour, caregivers should inquire about the ratio of caregivers to patients within the facility and the types of activities and services provided for patients. Caregivers can also note how staff are interacting with residents, the appearance of residents, and their overall impression of the facility. Are residents well groomed and dressed? How clean does the building appear? How much time did an administrative staff member take to answer their questions? All of these details can help a caregiver make a decision about whether a specific facility is the right fit for their loved one. Additionally, Medicare.gov provides a 5-star rating system, and I've included a link here to that system that caregivers can reference to see how specific facilities rate in terms of health inspections, staffing, and quality measures. These rankings are important to consider, and I always remind caregivers to also remember that these rankings only reflect one point in time during a state or federal survey that was conducted. So while this ranking is a helpful piece of information to inform a caregiver's decision, it shouldn't be the only factor that caregivers consider when deciding which facility would be the best fit for their loved one. Unfortunately, hospitals don't give caregivers much time to make these decisions. They often need to know where to send the patient within about 24 to 72 hours, which can be really hard on caregivers. If possible, caregivers can also ask family members and friends who know the patient well to help them with their search by pre-screening buildings to see if the caregiver should even spend time making a visit. I recommend calling in advance to see if you can receive a full tour of the building and extra time to ask questions, so you make sure that your questions are answered. So I also wanted to provide some helpful information for caregivers to access once their loved ones have been admitted to the skilled nursing facility. Sometimes much of this information is covered in the admissions process by an admissions coordinator or a nurse. However, there are many circumstances that might cause a caregiver to receive less information, such as the admissions coordinator maybe being out of the building at the time of admission, a facility with less thorough admissions processes. Maybe they just don't have a very thorough admissions process. A patient transferring to the facility after 5 p.m., that can reduce the amount of information a caregiver receives, and so forth. So there's lots of reasons why this information might not be shared with a caregiver or family member at admission. A social worker or nurse manager can often provide this information for caregivers, and I suggest that caregivers keep a notebook or electronic record with this information so they can easily ask for the appropriate person when they have questions. Especially in the time of COVID-19, it's very important for caregivers to know the facility's visiting policies, for example, meal schedules, rehab schedules, and various activities offered. This information can help caregivers plan their visits appropriately and decide if they wish to be present during certain tasks such as rehabilitation therapy or other tasks, if possible. Caregivers can also ask the facility social worker for assistance with completing advanced directives, such as a medical power of attorney for the out-of-hospital do not resuscitate form. And they can ask about referrals to various community resources, such as support groups or medical equipment companies. I will also go over discharge planning in just a few minutes, so I'll get into more detail around that process. It's also helpful to have the names of those working with the patient, such as nurses, nurse aides, the administrator, social worker, director of nursing, dietary director, and housekeeping director. I know that seems like a lot of names, but when you want to talk to someone about the fact that your loved one does not eat green beans and will never eat green beans, you're going to want to talk to the dietary director. And so you want to know their name. It's a lot easier sometimes to find them in the facility or to ask for them if you have that name readily available. This information just helps caregivers know who to call regarding their various questions. And that can really reduce the frustration that caregivers experience in this process of having their loved one in the nursing facility. It's also important to know about the various additional services that patients could receive, such as psychological, psychiatric, music therapy, and pet therapy, just to name some. And last but not least, caregivers should ask when the first interdisciplinary care plan meeting will be held. This meeting is when the caregiver learns about the patient's progress in rehabilitation therapy, their overall health status, and recommendations for discharge. And I have more information on care plan meetings on the following slide. So I'm about to say a lot more on that topic. All right, so how can caregivers access information? Again, when I was a director of social services for almost a decade, I often heard from caregivers in the skilled that had their loved ones in the skilled nursing facility that it was difficult to get clear information about how their loved one was doing overall, even though they were asking a lot of different people, but they really were having a hard time getting a clear picture. Here are some of the best ways to access information about a patient's progress when they are in the skilled nursing facility for a short-term stay. One of the best ways to get this information is to request an interdisciplinary care plan meeting, as I mentioned. This meeting can include all of the professionals listed here and is usually scheduled within 1 to 2 weeks of a patient admitting to the facility. While all of the professionals listed here should attend a care plan meeting if they are working with a patient, many care plan meetings are only attended by the professionals that you see highlighted in green. And I really think that's due to just some of the staffing issues and how stretched many staff members are in skilled nursing facilities. But I mentioned this point so caregivers can request the professionals that they wish to see in attendance for their care plan meeting. So, for example, if you want to speak with a dietary or food service manager, then I really recommend advocating that they be present during that interprofessional or interdisciplinary meeting. While these meetings are held around the time of admission and once every 90 days, if the patient ends up staying in the facility longer, a caregiver can request a care plan meeting at any time. Another great way to access information within the facility is to schedule a meeting with the social worker. While the social worker can't answer every question, they can point the caregiver in the right direction in terms of how to access important information. And they can help them access, of course, community resources, as I mentioned before, and help provide brief supportive counseling around the various stressors related to their loved one's change in condition, because it is a very stressful time for caregivers. It's best to schedule a meeting with the social worker because they are, of course, very busy. Their office door might be open, but they are usually running about 90 miles an hour in these buildings. So I just recommend that you make that appointment, and that way you get, some quality time. And then caregivers can also begin to plan ahead by speaking with various providers they will be working with upon discharge. For example, if their loved one will be using home health services, caregivers can get the referral information for the home health agency. They can get that from the social worker and reach out to the home health agency with questions about their services. Caregivers can begin to get a sense of how their schedule or their routine is going to be impacted by the services once they are initiated after discharge. Okay, so whether it's 2 weeks after admission or 2 months after admission, discharge planning can sneak up on caregivers. It just happens. Everything's kind of running smoothly, and then all of a sudden, the social worker or the nurse calls and says, we're going to discharge your loved one in about 48 to 72 hours. It can really feel like a surprise. The first question that can help inform the caregiver is, why is the discharge happening? I know this sounds like a pretty basic question, but I have seen a lack of clarity provided to caregivers around exactly why their loved one is being discharged from the facility at a specific time. For the most part, these are the 4 reasons a patient receiving short-term rehab services might be discharged from a facility. The first reason is that rehabilitation therapy might be ending due to a patient reaching their fullest potential, or what a rehab therapist might call plateauing. They have plateaued with their progress, or because their insurance coverage has run out at this point, and that can absolutely be the case. The patient or caregiver might also decide that they are ready for discharge, even if the patient has not completed their therapy regimen. And this does happen fairly frequently. This sometimes happens when a patient is experiencing emotional distress from staying in the facility. For people living with dementia, the skilled nursing facility might be overstimulating, or they might feel isolated being away from their loved ones for so long. Even though a patient could benefit from additional rehab services, the caregiver might decide to take them home earlier for their overall well-being, which is totally understandable. Sometimes the patient is moving to another level of care. That's another reason why they might be discharging. And this can be due to specialized needs, such as a patient that needs intensive wound care, or a patient that needs more intensive psychiatric care due to mood or behavioral disturbances. And then finally, there are times when a skilled nursing facility just can no longer meet a patient's needs, such as situations when a patient is engaging in aggressive behavior toward other residents without any improvement over time with medication interventions or social interventions. This type of discharge is usually reserved for very serious situations when all other interventions have been tried. But no matter what the reason for discharge, a facility social worker should absolutely assist the caregiver or family with finding appropriate resources to support the patient's care needs and to support the caregiver. All right, here is a checklist that I hope will be useful. This is meant to help caregivers determine their loved one's care needs at the time of discharge. This is a helpful list to have when discussing discharge planning with various members of the care team or during a care plan meeting. It's important to know, what is the patient's medication regimen? What is the appropriate level of care for this patient now that they've had a change in condition? What kind of assistance do they need with activities of daily living, such as bathing and incontinence care? What equipment needs do they have? Is a wheelchair now appropriate? Maybe they were using a walker before and now they need a wheelchair. What about wound care? Who will be providing the wound care? Will home health nurses be coming out and assisting with the wound care and infection control? Mobility restrictions are really important to know about. Does the patient have full weight-bearing status or partial weight-bearing status? This is an essential piece of information to prevent additional injury, right? And not landing back in the skilled nursing facility. What are the mental health needs or emotional support needs of both the patient and the caregiver? And of course, dietary restrictions. A lot of folks, need to limit salt intake, need to limit sugar intake, and so forth. And then, of course, the level of care covered by a Medicare, Medicaid, or another insurance. right? Just because a patient needs a certain level of care, we must know whether or not their insurance will actually cover that, because otherwise we're creating a potentially additional burden for the family by sending them somewhere where their insurance does not provide good coverage. And then also knowing what care needs are not covered by their insurance, such as attendant care. Most attendant care, meaning assistance with bathing and dressing and so forth, is not covered by Medicare under home health services. And so really that's an out-of-pocket expense for many people unless they have long-term care insurance. Okay. One of the most important questions for caregivers is which level of care is most appropriate for my loved one? The answer to this question really depends on at least three factors. And that is the level of care needed, the level of care recommended by the interdisciplinary team, the patient and caregiver's preferences, right? Where does the patient and the caregiver actually want the patient to be? And of course, as I mentioned, insurance coverage. So all of those factors need to be considered as a determination is made about where the patient will ultimately land after discharge. For example, the interdisciplinary team might recommend that a patient stay in a skilled nursing facility for long-term care due to their lack of safety awareness and their inability to safely ambulate with a walker. However, the caregiver might decide that they would prefer for their loved one to live in a smaller personal care home with only 4 other residents and very close supervision. If this particular patient has Medicaid coverage, they will be covered to stay in the long-term care facility, but Medicaid might not cover the personal care home that they select. So again, we can see how these factors come together and really give the caregiver really important information that can help them make the best decision in that moment. Another example would be when an interdisciplinary team recommends hospice services for a patient, but the family does not feel ready for this level of care, which is understandable. Since Medicare covers both hospice and home health services upon discharge, then the family can decide which level of care they prefer at that time. And then they could transfer to hospice services at a later time when they might feel ready. These examples are meant to help demonstrate why it's so important for caregivers to advocate for as much information as possible about the appropriate level of care for their loved one upon discharge. Okay. All right, so my loved one is going home. Which services do they need? It's a really, really important question. Based on the recommendations from the care team at the skilled nursing facility and what is in their loved one's best interest, the caregiver might decide that their loved one should ultimately return home. At this point, it's crucial to consider exactly which services will best meet the patient's needs. This decision depends on, again, the level of care needed by the patient's abilities, such as their ability to dress and groom themselves, and once again, the insurance coverage the patient has for various services. For example, hospice care is covered by Medicare, but in-home attendant care is only covered by long-term care insurance or potentially VA coverage. Most patients have neither long-term care insurance or VA benefits, or many patients don't have those, meaning extra attendant care is often an out-of-pocket expense for patients and caregivers. Some caregivers would prefer for their loved ones to attend outpatient rehab therapy, for example, rather than being homebound with home health services. However, then there is the additional task of transporting the person with dementia to and from the outpatient clinic. It's a really important factor to remember. All of these factors should be considered, but one of the most important questions for caregivers, and one that I ask many, many times in many, many care plan meetings, is for them to ask themselves, before deciding on a level of care, who will tend to each caregiving task? Who will be in charge? Who's going to do this work, right? So for example, if the patient is now incontinent after leaving the skilled nursing facility, who will be assisting the patient with changing their adult brief each day. And sometimes caregivers have not always thought through exactly who will be handling the various tasks. And there are many, many tasks to consider. Answering these questions helps caregivers think comprehensively about which services they will need to be successful at home, and to grapple with the difficult question about whether returning the patient to home is the best decision. And that's a really hard decision for all caregivers to make. It's certainly a personal and complex decision for each caregiver. And I hope this information helps caregivers make more informed decisions about this care transition. So just a couple more slides here, and then we'll open it up for some questions. But I provided this step-by-step list to help caregivers know, how does the discharge planning process work? It can seem like a very mystical process, and nobody can really answer questions, but it's really important to kind of know what is happening at the point of discharge. This process begins with the interdisciplinary team recommending that a patient be discharged based on one of the reasons that we've already covered earlier in the presentation. When this decision is made, an interdisciplinary care plan meeting should be held with the caregiver to inform them of the reasons for discharge and the recommendations for the appropriate level of care. The physician then writes the orders for home health or the other services that are needed, including orders for the level of care and all needed medical equipment. So the physician should really take care of writing all of those orders. And then the social worker or nurse then sends those doctor's orders to the various service providers chosen by the family, such as home health or hospice or the durable medical equipment company. Often the healthcare providers and durable medical equipment companies will contact the family member or the caregiver. But I encourage caregivers to reach out to these agencies if they haven't heard from them within 48 hours of the referrals being made, because it's really important to touch base with them and find out, what are these services going to look like in my home? The caregiver will be notified of the date and time of discharge, which should allow for preparation of the home and preparation for transportation. The charge nurse on the patient's floor, that's what we always call them, the charge nurse or the head nurse, is usually the one in charge of preparing the paperwork, including instructions for medications and other equipment to be sent home with the patient, such as syringes or wound care materials as well. And when the patient is actually discharging, the charge nurse will go over the discharge instructions and medication list with the caregiver. And then the caregiver or medical transport brings the patient home or to the receiving facility. I will tell you, the social worker is often the person who is coordinating all of this. And so when you have questions about kind of where your loved one is in this process, I really recommend reaching out to them, because they are stewarding this process. And I steward this process for many years. It's kind of like putting a complex puzzle together. I really enjoyed it, and it's very complicated, as you can imagine. All right, so this is a last slide for the day, but I want to leave everyone with a practical toolbox, as any good social worker would do. This is just a quick skilled nursing facility discharge planning toolbox for caregivers with questions they should ask regarding the discharge planning process. This list incorporates all of the information I just covered on discharge planning, but it can be helpful to have this list of questions to make sure the caregiver feels as prepared as possible for their loved one's transition out of the skilled nursing facility. A couple of these questions ask about insurance coverage, and I want to end by emphasizing how important it is, again, for caregivers to ask about co-payments as they are authorizing services. For example, home health and hospice are often covered at close to 100% for people using Medicare who are discharging from a skilled nursing facility. However, there are often co-payments of 20% on various types of medical equipment. And then, of course, attendant care services are not covered by Medicare at all, as I mentioned before. So asking about these fees and for various services as soon as possible can help caregivers understand how changes to their loved one's care will impact their overall budget and whether or not this plan of care is feasible to begin with. So with that, I will conclude and open up for questions, and thank y'all so much.